podcast with me, Dr. Amy Burbridge. I'm a consultant in acute and general medicine in the United Kingdom. And today I am joined by my ever brilliant psychic.
Hi, Ben Lovell here. I'm a consultant in acute and general medicine as well, working in London.
Great. So I've got a case for you today, Ben. This is a case of a 61-year-old female who I first saw 2 months ago. So she presented to the same day emergency clinic with central chest pain and right hip pain. She looked very well. And when she presented to ESTEC, I did an assessment immediately. I didn't do any bloods or investigations at that time. I took a history and she'd had this central chest pain, which she described as a burning sensation, worse on eating, radiating through to the back, right at the centre of her back. Nothing really made it any better, but certainly eating did aggravate the pain and discomfort. There was no radiation of the pain to the neck or the jaw, and there was no radiation to the arms. There was no associated shortness of breath, no cough, no wheeze, no fever, no sweats, no nausea, no vomiting, just this chest pain central that felt like a burning sensation. She then said to me, I've also got this right hip pain. I've had this hip pain on and off for a couple of months and I've seen my general practitioner a couple of times, but recently they've started me on naproxen. So that's an anti-inflammatory and non-steroidal anti-inflammatory drug, and she'd been taking this on and off for a couple of weeks. Hadn't co-prescribed a proton pump inhibitor. So my assumption was that this patient had naproxen-induced esophagitis and she had dyspepsia because of this. She had some routine investigations done that had been requested before I'd actually had a chat to her, and completely normal, apart from a raised D-dimer. And the raised D-dimer was 0.79. So I had to then think, would I have done this blood test if I'd not requested any blood tests before? Would I have then requested this after the history and after the examination? Does she have a high clinical probability of having a PE or a DVT? No. So actually, I thought, I'm going to park that D-dimer to one side. We did a chest x-ray, completely normal. We did a ECG, which showed no signs of a PE. There was no sinus tachycardia. There was no S1Q3T3, that very rare sign you occasionally might see on an ECG. There was no ST elevation, no ST depression, no right bundle branch block, or no right-sided heart strain on the ECG. So I assessed her, I examined her. Examination was essentially completely normal. She looked really well. She had a little bit of tenderness in the epigastric region. She said that she was quite stressed. She's had some difficult time with her family and at work recently. So we had a really open and honest conversation. I spent quite a bit of time with her and said, you know, I think you've probably got a bit of indigestion. You've had some naproxen. You've got a lot of stress going on. Actually, maybe do a bit of self-care. You know, I think the hip pains, she was known to have a bit of osteoarthritis. I think a lot of things have got on top of you. Maybe take some time out, take some time to, look after yourself. But I'm not worried that there's anything at all to be concerned about. End of consultation. Any thoughts?
Well, yeah, that sounds exactly what I would do. So she's got classic symptoms of GORD in the context of NSAIDs with no gastroprotection. And with regards to the D-dimer, you're right, the pre-test probability, the Wells score, is going to be super low, if not zero. And she's gone with clinical DVT, has she? No.
There was no signs of DVT peripherally. She looked well.
Yeah.
It was nice. We had a nice consultation. We had a nice chat, made her a cup of tea, and she went home. She was happy with my diagnosis. She thanked me for the thorough consultation and left. So
you spend a lot more time, it sounds like, going through her life events than I even would have. I would have discharged her home. The D-dimer, as you say, is mildly elevated, but she's 61. And I know that age-adjusted D-dimers are not, well, maybe I'm wrong, are not completely validated yet for clinical practice, but your D-dimer does drift up with age. I know as a general rule of thumb, we use slightly different units to you. So your D-dimer of 0.79 in my hospital would be 790. And I know that as a general rule, your age multiplied by 10, it can be, which would be 610 for her. It's not too far off. But without a probability of a PE, I mean, unless who does the blood tests in your estate? Do you request them, or do they get them automatically done, or does a clinician decide on the way in? Or
so again, this is something that's up for discussion and debate, but they are normally requested and taken before I've even seen the patient.
Okay. I just wonder if somebody heard chest pain going to the back and they thought, thoracic aneurysm rupture, and that's where the D-dimer floated from. But people who have, you said a chest X-ray was normal with no mediastinum widening, and people who have a dissecting aorta tend to look a bit peaky, as they dissect the major artery in their body. They tend to look a bit unwell. So it's weird for them to say, I've got burning pain when I eat my dinner and go home. So I think I'm thinking aorta, but I can't really justify a CT aortogram to rule in or out that diagnosis based on what you've told me.
And that's what I was thinking. She was happy with the plan, had a quick chat to the husband as well, and they went home. Now, she came back in a week after this and wasn't seen by me and was seen by a different clinician. And she again presented, she said she'd been taking the PPI that I prescribed her. She'd actually stopped taking the naproxen that I'd advised. She was taking regular paracetamol, and the hip pain was okay, but she still had this pain in the chest and she just didn't feel right. So her blood tests were repeated with a repeated D-dimer. D-dimer was again 0.81, so subtly elevated, and she went down the CTPA route. CTPA was done that day, and the CTPA was negative. There was no PE of note. In fact, the CTPA was completely normal. So again, she was reassured and sent home to continue the PPI, to make sure she's definitely not taking that naproxen, and to try and stick to paracetamol, codeine maybe if required. And again, she was happy with that.
Well, and this is a retrosternal chest pain, right? It's in her chest. It's not in her abdomen. It's not a grumbling gallbladder or anything like. It's not biliary. It's central chest.
Good, really good question. So it was very central chest. Her abdomen was soft and non-tender. You're right to think biliary, actually. She's sort of in that age range. She'd have that indigestion. So yeah, should we be looking at a gallbladder? But the abdomen was soft and non-tender. Her bloods were normal. Liver function completely normal. Bilirubin, alkaline phosphatase, ALT, all normal.
Right.
So it may have entered my head, but I was like, actually, it doesn't really fit. So sort of ignored that. So again, I didn't really think much more about this case until last weekend. And I did the long weekend at work over the Easter bank holiday, and it was Sunday morning, and it was around 9 o'clock, and I could see this lady, and I was like, oh, she's in hospital. So the first thing I was thinking about, what have I missed?
What have I done wrong?
What have I done wrong? Because this was probably about 3 to 4 weeks after I'd initially seen her.
Yeah.
And I was doing a ward round, and I remember the bed she was sitting in. She was you walked into the ward, she was on the bed on the right-hand side, nearest the exit. And I went to see her. She was like, oh, it's lovely to see you, Amy. How are you? And I was like, lovely, but what are you doing here? I thought you were absolutely fine. And she said, oh, I came in yesterday because I can't feel my legs. And I was like, okay, so tell me more. And she'd been seen the day before, and she'd presented with bilateral leg weakness, was still able to walk and mobilize, but her legs felt weak, and bilateral pins and needles. And I was like, okay. So the plan from the previous day was, let's do an MRI, urgent MRI, to look at the spine. But she was so claustrophobic, she didn't want one. So they suggested a CT myelogram, but we don't do those. It wasn't something that we could provide on the Saturday. So she had a plain CT spine, which was essentially normal. It showed a little bit of disc collapse, but there was nothing really significant of note identified on this CT scan. So I went to see her, went back to the history, and she said, I'm completely paralyzed. I can't feel anything. And I said, sorry, what do you mean? And she said, well, from just underneath my breasts, I'm completely numb. And I was like, okay, so can you move your legs at all? No, I can't feel anything. And when did this happen? Last night about midnight, suddenly came on. Any pain anywhere? No, I just can't feel anything. Do you know when you need to go to the toilet? Do you know when you need to open your bowels? No. Do you know when you need to have a wee? No. So she'd got a catheter in, and any pain, what about the pain in your chest? And she went, oh, the pain in my chest's gone. I was like, okay. Any breathing problems? No, no problem. So I wanted to find out if this neuropathy had it ascended or descended because of the rapidity of the onset. And she went, it felt like it started in my feet. But to be honest, I'm not entirely sure. It could have started higher up. Have you got any pain in your back? Yeah, she said, you know that pain I had when I saw you in my chest? Well, the one going through to my back, that's there. Okay, so I'm going to stop there because I've told you a lot of information. So any thoughts?
Right. She is describing to you what sounds like a T5 cord lesion with sphincter involvement. Did you say numb or weak or both from the sort of nipples down?
Both.
Did she have any reflexes in her legs?
She was completely areflexic.
Okay, and no power at all, and has
nothing.
Lost sphincter control. And she had a PR exam or anything like that?
Yeah, so the PR exam was done and she had no anal tone at all.
Right. Upper limbs were spared?
Upper limb was spared. So I did a full neurological examination, cranial nerves, upper limb, lower limb, and upper limb and cranial nerves were completely normal. But the lower limbs, again, there was no tone. She was areflexic, power, there was nothing. There was not even a flicker of muscle.
And it wasn't a sudden onset. You said it's ascended from her feet.
So she wasn't sure whether it ascended or descended, but the day before she'd come in because her legs felt a little bit weak.
Right.
And on the Friday, she said, you know, that hip pain, the hip sort of was troubling me and I couldn't really walk as well. I thought it was my hip pain, but that's now gone.
Okay.
And on the Saturday, she felt weak and had pins and needles bilaterally, but was still able to walk and mobilise to the toilet and back. Okay. Still had full bladder and bowel control on the Saturday afternoon.
So it was a subacute onset. So she's got a cord lesion to me. She needs urgent imaging of the cord. She needs to take a Valium and get in the MRI scanner or however you're going to get an imaging done. But she needs to get in that scanner ASAP. And I think that in terms of what the lesion could be, it doesn't sound like a vascular lesion because it wasn't sudden onset. What could present over a period of time? Has she demyelinated? Is there inflammation there? Is my question at the thoracic spine level. And retrospectively, was the pain? Did it sound like a neurological pain? She said burning, didn't she? But it wasn't coming around the sides in a dermatomal pattern, no. Okay, in that point, I can't force this to fit with her initial presentation, but based on this new presentation, she needs an MRI of her cord on the urgent side of ASAP, doesn't she, to see what we can salvage, really, and what the diagnosis is.
Yeah, so I panicked. I felt sick. I didn't really know what to do. She needed an MRI yesterday. She was so anxious, and your response of, she needs to take some diazepam. I actually said that to her, which probably wasn't the right thing to say, but I was like, you really need to have this scan. And I don't think she fully understood the implications of what had happened to her, to be honest.
Yeah.
And I was trying to explain that, you know, I'm obviously really concerned now. You've got this complete weakness and numbness that suddenly came on. So we really need to do that urgent MRI scan now. I need to find out what is going on. So I spoke to the medical registrar on call at the local hospital, who happened to be a trainee that I knew, and spoke to the neurology registrar as well. And they agreed to obviously see the patient as soon as she arrived in the hospital. They requested the MRI scan before she'd even arrived there. Spoke to MRI, who said, yes, we'll scan straight away. Called an ambulance, and she was blue lighted as an emergency over to the A&E department there, where she had the MRI scan literally within minutes of arriving.
Good.
It was incredible. Like, I was so impressed of the teamwork, the response, you know, how helpful everybody was. And it really reaffirmed my faith of how incredible healthcare can be, even though I was, 10 miles away in a different hospital trust. Everybody came together and it worked brilliantly. So I really do think that even though the patient was in a smaller hospital, she still had an excellent level of care because we had that communication at the right time in the right place.
Sometimes this works, yeah, and it's important to acknowledge when it does. There's a lot of stuff out there saying that humans tend to give more weight to negative experiences. If something goes right 5 times and goes wrong 1 time, we tend to go, oh, this never goes right. This needs to be changed. This is in all walk in areas of life. So it's important to recognize the wins when they happen.
Yeah, it was really showed how things can work well and how good communication, it really is the key to good healthcare. So she went over to the local hospital and she had a MRI, total MRI spine. And this is where things get a little bit interesting. So the MRI showed a significant lesion at T4, which was expected given the numbness and the abnormality. So the patient went straight to theatre. The neurosurgeons took her straight away and she had decompressive surgery. And interestingly, the lesion was at L2. Okay, so I looked at the surgical notes because I think it's really important to reflect. So my thought when I'd initially saw her was this is a T4, T5 lesion. I'd even got the dermatomal chart out to like try and remember, where the dermatomes were and what they did. And I then looked at the surgical notes, and the surgical notes say that there was a large disc fragment removed at L2 vertebrae, immediately decompressing the thecal sac. Exploration in the disc space also shows there was additional removal of further disc fragments, but nothing else of note was identified in the spine. So this is where things get interesting. Her MRI showed multiple bony metastases throughout the spine. The subsequent CT thorax abdo-pelvis that was done to try and identify primary was completely normal, and subsequent MRI shows no metastases. What is going on? We are still confused, to be honest, as to actually what is going on. We know that she had decompressive surgery at L2. We have some scans showing cancer. We have some scans showing no cancer. The CTPA that she had done with us a couple of weeks before was negative and blood tests were normal.
So just to clarify the timeline, she has her first MRI, which shows multiple metastatic deposits in her spine. And it must have shown something at the L2 if they took her to theatre and cut L2 out.
Yeah, absolutely. So it showed a lesion at L2 that they thought had got some cord compression.
Okay. Then she goes to theatre and has a disc removed from the L2 region. Then she has another MRI, which is clean.
Yes.
Okay, well, something has gone awry then in the radiology department. So this is a great opportunity for a nice MDT with a neuroradiologist, a neurosurgeon, and anyone else with a stake in this patient's care to get together in a room and look at the 2 MRIs together and work out what actually is the situation here. Has that happened yet?
It's happening this week, actually. So I completely agree with you. So it made no sense. So when things make no sense, what do? We have to, again, it's uncertainty, isn't it? We've talked about uncertainty before, but there's all this uncertainty going around. So now we need some second opinions. We need to make we need to get a team involved, don't we? We need to get a multidisciplinary team involved. We need to look at the scans. We need to look at the whole picture, and we need to get the right people involved around the table at the right time to discuss this case as a multidisciplinary case.
Yes.
Her blood tests are reassuringly okay, aside from the fact she had a multiple myeloma screen with a raised kappa, a raised lambda in her bloods, but the ratio was completely normal, so they don't think it's multiple myeloma. So at the moment, we still don't really have a diagnosis. But what I really wanted to highlight with this case, and I guess discuss with this case, is did we miss something a month ago? Could I have prevented this admission? Could I have prevented this complete paralysis? Did I miss something? Did I do something wrong?
I'm racking my brains here. I'm trying to think how. Okay, so first of all, I will say that I have seen a patient once before when I was a neurology SHO who had a very similar presentation. She presented with spinal compression. She had imaging which showed multiple spinal deposits, bone deposits, which are nets, no primary identified on cross-sectional imaging. And she had a biopsy of one of the spinal deposits, and the histology of that showed undifferentiated adenocarcinoma of unclear origin. And the woman died with a diagnosis of disseminated malignancy of unknown origin with spinal mets. So people do walk this earth with that horrendous diagnosis, which must be profoundly distressing and frustrating to them and their loved ones, not knowing what it is which is affecting you and, you know, is shortening your lifespan. But I've seen this before. My next thought is that well, no matter what the two MRIs show, there is something going on at T4 and 5. Although she's clear as day pointed to that area as essential, that's her sensory level. She's clearly telling you clinically that there's something going on there. So no matter what the MRIs have shown, they need to have their MDT and focus on the thoracic spine, basically, because something is going on in the cord. It's as clear as day. You cannot, you know, be mistaken with those signs. So that's something else for them to focus on. L2 makes no sense to me. The third thing is that, was this burning central chest pain going to her back with hip pain, a spinal lesion or a spinal disease presenting in an atypical way? I can't make that make neurological sense here in my head unless her hip pain was referred pain from the L2 dermatome that she was localizing to hip. And in fact, it was some kind of ridiculous L2 pain which was crossing the hip. But I'm really reaching here. I can't, it's not a very satisfactory diagnosis by any stretch. I wonder if she actually has two separate things going on. The spine was cooking away in the background with whatever pathology that will turn out to be. But she also came to you with GORD and a poorly hip, an arthritic hip. And that's what you saw and that's what you treated. Now, whose law was it that says that patients are allowed to have as many diagnoses as they please? I can't remember.
It's Hickham's dictum.
Hickham's dictum. And I think I wouldn't try and force two jigsaw pieces together that simply will not go. I'd be very interested to hear the outcome of your MDT. And, you know, I heard a brilliant neurology talk very recently where they're saying that when you request a scan and when a scan gets reported, be that CT, be that MRI or what have you, they will answer the question you've written in the scan request. And if you've said, for example, severe pain at T4 sensory level, they'll look at T4 and they might miss the big pathology at L1 because they're not looking at it. When you then go back in an MDT discussion or simply with a one-on-one conversation with radiologists, say, we've got a new question now, is there L2 pathology? It suddenly turns up stuff. They can only answer what you put. I think I've talked about this before, but the beauty of these MDTs is you can say, okay, we have a new question now, get these scans up and let's see what we can see on these scans. And you can't really say, oh, you missed something in the first scan. It's a massively complex scan and they were answering your clinical question. So what data you put in your scan request is absolutely crucial. And if you put in something, I mean, just theoretically, if someone put in spine pain query cause, weak legs query cause, you are going to get much less out of your report than if you put in patient has clear signs of cord problem at T4 level, including a reflection in the lower limb, zero power, sensory level up to T4, for example. So that is where the MDT will actually reveal, I think, a lot more data than you have at the moment.
Yeah, I mean, you've raised some completely valid points there. And, you know, I completely agree with everything that you said. However, I can't help feeling that I messed up. Because was this, like you say, was this burning pain in that T4 region? Was it that, you know, metastases? Should I have looked into it more? You know, should I have scanned the spine? You know, would I do things differently next time? Potentially. But then you can't scan everybody's spine who presents with this type of pain because it's so frequent. It's been I've reflected a lot on this case and it's still ongoing now. So, we still are entirely unsure as to what is going on, and I will make sure that we do update on what will happen and what the eventual diagnosis is. But it's, when I see patients in same day emergency care, they look well. Therefore, they must be well. And sometimes, because of this, I think sometimes where we see patients really dictates sometimes our diagnoses. So if I see somebody in a bed, in pajamas or in a gown with a blood pressure cuff on them, with a cannula in them, they look ill, even if they're not. And sometimes I think our diagnoses are skewed by the location we see a patient, potentially. So if somebody walks into SDEC, fit and well, in their own clothes, on the laptop, doing the work, and they say, oh, by the way, I've got this chest pain, I just need to send this email, things do look different and they feel different. And I do wonder whether I'm now much more aware of that after this case.
That certainly resonates with me. It makes me think of when I do my ward rounds and I see patients, especially older, frailer patients, tucked up in bed. And I think they're going to be in for a few days, actually, because, they look quite frail and weak. And I haven't seen them out of bed at all. And apparently they live on their own with 2 carers a day. So they're not going to manage that. And the magic happens when the therapists come to see them, the physios and the OTs. And then we catch up at our afternoon MDT meeting and they say, we got her out today. She did the stairs. She walked here. She walked there. We gave her a frame. We've given her a better fitting pair of shoes. And she's going to go home with her. They're going to assess her at home. And that is absolutely transformative. But my snapshot, and my ward round start at 8 a.m., my snapshot, somebody hasn't quite woken up yet, hasn't had their cup of tea, and also is lying in bed, is very, very different from someone who I see walking down the stairs or working with the physio down the ward with a frame looking great there, Mrs. Jones, we'll get you home, no problem. They look like a different person. And I think it does have a big impact. I recently had a patient I saw in A&E who looked too well for his diagnosis, and he was a young guy who was about my age, really, so far too young to have any heart problems. And he came in with some chest pain. I thought it was during the strike week, or so we were covering, we were seeing patients directly as consultants. And I went to see him. I was like, oh goodness, why didn't he send him home? And he's pain-free now, and he looks healthier than me. He cycles all around London for a living. And the patient just gave me a beautiful story for crescendo angina and unstable chest pain. And I tried to make him be able to be discharged, but I couldn't do, because he looked well. He looked well in his own clothes, sitting in a chair in the waiting room, but I couldn't do it because everything he said was like, oh gosh, you're going to have an angiogram before the week is out. I can sense it. So yeah, I think we are very prone to making judgments based on how do they look. End of the bed test, end of bedogram is the test when we clock someone. And I think we make a very, very quick unconscious assessment of how well that patient is and how well they're going to do in the next sort of 24, 48 hours.
Yeah, and I think, so there's a really famous book by Malcolm Gladwell called Blink, and that we make a decision about a patient in the blink of an eye. We make a decision about a person in the blink of an eye. You know, what clothes they're wearing, what perfume they're wearing, what shoes they've got on. And I used to put quite a lot of emphasis on the end of the bed test. Do they look well? Do they look unwell? Since this case, it's got me thinking a little bit more about, am I putting too much emphasis on that? Or have I just been completely skewed because of one challenging case that I feel like I missed something on? In a very well patient, did I miss this horrible underlying metastatic malignancy? So it's just made me really rethink it, I guess. And also it's made me challenge, I guess, even though I'm a consultant, and I think that I'm not stuck in my ways, I'm always open to change, but actually we can change how we think and how we practice, even as consultants. And I think we should always be trying to improve.
The trick Definitely. Is to have an open, curious, reflexive mind at all times. And it's difficult to maintain that state of consciousness because the NHS does not tend to inculcate that attitude with the pressures that we work under. I think just to quickly revisit your specific case, I absolutely, even with the benefit of hindsight, would not have done a CT spine. I think you said her CT spine was normal, right? Because she couldn't have the MRI. It would have got you nowhere. So your real question is, should I be MRI spying all these patients who come in with central burning chest pain and hip pain? And I think you know the answer to that is a no.
Yeah, I know. I guess it raised a lot of points for me. So I guess moving forward, the key things that I want people to take away for this are, again, the uncertainty. Even though this individual has now been in hospital for nearly 2 weeks, there is still uncertainty about the diagnosis. And, even with lots of investigations, a thorough history and examination, even having major surgery, uncertainty still remains. And I guess secondly is where you see a patient can influence your diagnosis. If you see somebody in resus, you're probably more likely to diagnose them with a more serious condition than if you're seeing them in same-day emergency care clinic room. Any learning points for you, Ben?
I think that's great. I think you're allowed to be in a bit of a tailspin for a while when you have a tricky case. It reminds me of we did a podcast episode a while ago called Paralysis, if you want to go and look at it. And I was in a very similar situation, and it really affected me very deeply. And I think the best way forward when you have, and every clinician has these cases, to try and make sense out of it and work out how you're going to reframe things going forward, is to reflect. And that's what we've just done now. But it's talking it out loud and reflecting it on someone like a supervisor or any other colleague is much better than the alternative if you don't, which tends to be rumination, self-recrimination, and ultimately avoidant behavior, where you never want to see a patient with that condition ever again. And it's much healthier to try and make sense of it and reflect it out, either by using a reflexive model that you like, or simply by talking out with a colleague and just getting a bit of a sense check, which is what we've done here today. So hopefully that's been useful for people to listen to.
Yeah, thank you as well, Ben, because it's actually what I needed to do was have this reflective discussion, and I've just had it in front of thousands of people. So, I think we definitely need to do this more for cases that we see. Thank you so much for taking the time to listen to me Twitter on. I hope that everybody's enjoyed listening. I hope everybody's got some good learning points, and we'll be back very, very soon. Thanks for listening.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.